Good morning, good afternoon, or good evening, everyone. Welcome to today's special VMR. Today we have something special for you in store. Rabih had the idea of starting with like a rapid response VMR. And yeah, so here we are, giving it a shot. Today I'm here with the one and only Rabih, and we will both try to tackle this case. I think Rabih always has great cases, and we all learn so much from it. I'm already a little bit nervous when I'm thinking about rapid response VMR, but I think we are very privileged. We can sit here and discuss it, not to mention when we would be in real life where you aren't really able to think because you have to act so fast. And here we can sit together and learn. So I'm very excited for it. Rabih, how are you doing?
I can't wait for today. Sammy, sometimes this feeling that I'm having is usually one that happens after my pager goes off or I get a phone call. It's funny that I know we're going to be in an acute situation now. I've never had it before, but I'm really, really excited for it. So, Rabih, thank you for the constant innovation in VMR and really, really excited. I also am wondering if the mannequin behind you is going to be involved in this case. I hope not.
Yeah, it's
I wouldn't be surprised.
So this is Bob. It's one of the POCUS mannequins we have. So I had to store it in my office, and I thought, like, okay, but I actually could bring up the
scenery.
exactly. But actually, it's interesting. I had a thought maybe of doing this from the sim lab, since simulation is one of my interests, and gamification of clinical reasoning is kind of a new innovation. So I'm actually absolutely enthralled to bring this case, a case I saw a couple of weeks ago, and I thought, this is where the training and the thinking that we all do here on CPS comes into play. And I think it would definitely help a lot of incoming interns or interns transitioning from PGY1 to PGY2. Back to you, Rabih.
Well, amazing. Well, I think Rafa is telling us how nice Bob is in the chat. I think Sammy has got his smile going for the YouTube video. And so we're ready to go.
Okay, so one morning you're coming into work and you're instantly called for a rapid response on one of your patients. You have no idea what's going on with the patient, who the patient is, and the reason for the rapid response is altered mental status. I'll give you the vital signs as you arrive to the scene. Patient is found lying in bed, has a non-rebreather mask on, has making gurgling sounds, temperature 37.9, and heart rate 105, respiratory rate 24, blood pressure 191/93, and I'll stop there for discussion.
All right. Wow. So I will get this going. So we have a rapid response. We are getting called and we arrive in the scene and we have this patient in bed gurgling and on a non-rebreather mask, and he or she is tachycardic, tachypneic, and also hypertensive. So whenever I see tachycardia and hypertension, I think about sympathetic activity. So this patient is in distress. And the chief complaint is altered mental status. I don't think we would have the rapid time to think about our broad differential for altered mental status. I would maybe first focus on like whenever a rapid response gets called, that A, B, C, D, E is everything intact. So I would first check, is the patient, are there airways patent? Is there something obstructing? Is he having some sort of aspiration? So if that's it, so I would put the mask down, I would look into the mouth, see if there's something in there, if there's maybe edema or something going on that's like putting him into this distress. If that's present, I would like go to B, to breathing. I would get a pulse ox, check his pulse, his peripheral oxygenation. I would check his respiratory sounds over his lungs. If I hear something, if I don't hear something, maybe he is having a pneumothorax or something like that. Is he cyanotic? If I put the pulse ox on and I see that his saturation isn't too good, I would increase the oxygen, and especially call for help, that someone comes, for example, a respiratory therapist, and helps me with that. Then I would check C, what's the blood pressure. Here we see that he's hypertensive, so we could think, is that the main problem, or is this a consequence of his stress? So that a little bit elucidating for me that I will have to figure out. But definitely check what's the volume status. Is he having signs of bleeding or something with this blood pressure? He could still be bleeding somewhere, but could decompensate fast. And yeah, also then D, check his pupils. Are there signs for any intracranial hypertension? For example, Cushing reflex, he could be hypertensive because he has an intracranial hypertension. Check a blood sugar every time someone is altered. And at the last E, get exposure, like check, is there a rash, something going on? Is he having a peripheral IV that's like maximally inflamed or something like that? That would be my first approach. Rabih, what do you think?
Absolutely superb. A+, my friend. I don't think that there's anything really to add. I'll move us to the next step, which is to, once you've collected the data, what are some common empiric things you can do? And I think in the world, it depends on what world you're in. If you're in the world of altered mental status, the rapid things that you want to do are glucose and Narcan. And I think here the value of Narcan is reduced by the fact that the patient's respiratory rate is 24. It's still something you want to keep in your back pocket. But I think that here the glucose, as you said, is probably the first step in terms of altered mental status. In terms of the lung signal that we got, I think thinking that the fact that the patient has secretions means that either they're not being propelled because of a neurologic issue or there's an obstruction. So in the world of hyperacute pulmonary syndromes or thoracic syndromes, you don't really have many tools in your toolbox, but the most important one is to suction things and to suck things out of the chest. You can suction secretions. So immediately you're going to go with the suction while you open the mask. When you take the mask off, you're going to be suctioning to get a good view. And then don't forget that the other thing that is important to suction is to suction air out of the chest in the case of a pneumothorax. So immediately, like, sucks things out is a big, big reflex. The other big, big reflex is to think about the utility of blood pressure control and diuresis in this patient. And if he's really hypoxemic and hypertensive, empiric treatment for flash pulmonary edema is not harmful. So nitro paste and diuretic is something you'll think about in this patient. And you might think about nebulizers for the possibility of aspiration or airway issues. So as a sum total, suction, 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 I would say air out of the pleura and secretions out of the airways. And also, in patients, empiric treatment of airways disease with nebs, harmless. And in a patient who is hypertensive and hypoxemic, empiric treatment for flash pulmonary edema with nitroglycerin and furosemide with close monitoring of the oxygen blood pressure, also a very high reward risk ratio. All righty, Rabih, back to you.
Absolutely wonderful. Great job there, Sammy. Some great walkthrough of emergency measures that you would implement. So while you ask the nurse for the history of the patient, when you examine the patient, he's moaning to being stimulated in bed. His mucous membranes are moist. You find some vomitus on top of his chest over his gown. Cardiac exam is benign. Respiratory, there's rhonchi bilaterally. And again, he's on a non-rebreather. His extremities, there's no edema. He's perfusing, he's warm. And skin, there's no rashes. Now, getting to the neuro exam, both pupils are equal round and reactive. He's not opening his eyes to voice or painful stimuli. He does have corneal reflexes. There's no cough, there's no gag. He is extending his arms when stimulated, but there's no spontaneous movement. And when informed about his exam the day prior, so he was admitted 6 p.m. the day prior, patient was confused, was awake, was following simple commands, and again, the exam without the respiratory findings, but the mental status was slightly better than what he was presenting with in the morning. So back to you, Sammy.
Oh, okay, interesting. So he came in, he was able to follow commands, he didn't seem as altered, and his respiratory status was also a little bit better, right? Okay, so now when I'm hearing this physical exam, his cardiovascular exam appears benign, he's warm, he perfuses well, so I wouldn't think too much of a shock state, although we know there's like distributive shock that can present with warm extremities, but here he's hypertensive, so that argues a little bit against like a shock component. So I think the main thing we're trying to solve is like his altered mental status, and the thing that he doesn't open his eyes anymore, that he doesn't cough, that he has no gag reflex, signifies to me that he can't really protect his airways and is like at risk of aspiration, and he also vomited. So I'm pretty sure that he also has some sort of aspiration event going on. So I would really like start thinking about airway protection and proceed with intubation to secure his airways. And yeah, the thing that he's like reacting with extension of his arms is like also not a very good sign. You know, when you go down the Glasgow Coma scale, you have flexion and you have extension, and extension is usually worse than flexion. There's some localizing value to it. I can't say it now, but yeah, that's what I would be thinking right now. Like, does this patient need intubation for airway protection, and do we need to control his blood pressure if it's not secondary due to an intracranial process, because then you shouldn't decrease the blood pressure.
Absolutely superb, Sammy. I have nothing to add, but just to ask you, as you're thinking of these things, I imagine that imaging the brain is on your mind. What kind of things would you say? Like, you know, the intubation is happening in parallel, and you're tasked with putting in the order for the imaging of the brain. What might you think of doing?
Yeah, I have never been in this position, but I think I would get first a CT of the head to exclude hypertensive like intracranial bleed. To check for bleeding. Yeah,
100%. I think you have a very tricky situation here, twofold. One, I think the probability of this patient being intubated is very high now, but there are nuances. It's really important in this situation to try to figure out what the code status is of the patient, because we don't know anything about his background, and he may have an advanced condition in which intubation is not within his goals. So that's always really important. I think in this situation, preparing for loss of pulses is important. So placing the backboard behind the patient, again, sort of like thinking next steps. Can I intubate this patient? Yes or no, code status. Will this patient probably code? Yeah. So being prepared for that scenario with getting the crash cart close and putting the backboard behind the patient prophylactically, and even putting the defibrillator monitor on. You could start to think of those very important steps. In terms of the diagnostics here, I think you have a setup where you're being pushed into thinking that the severity of the problem is so severe that it must be in the brain. But I think severe hyponatremia, hypoglycemia are all still fair game here. So you're going to be pulled gravitationally towards an intrinsic brain process, but being open to the possibility there's something really bad outside the brain is important. My piece of advice in these patients is to always, you have to get a CT. You can't get an MRI. The question is, do you get a CT non-con, or do you get a CT non-con and then get a CTA, CT angiography? And I think that question is very hard to answer. My advice is, if you are at all thinking that there might be an acute ischemic event and or the possibility of vertebrobasilar insufficiency, you should get both. You should get a non-contrast CT followed by a CTA in one trip to the CT scan. So in this patient, if you say hyperacute encephalopathy with brainstem findings such as cough and gag, I think I would probably be inclined to get a CT and a CTA just with the data we have now. If we have more data based on what has happened. So summary, we think of brain imaging as binary, CT and MRI, but remember that the CTA is a great in-between test that helps you answer a lot of other questions and can be done just as quick as a non-con CT. It requires very good vascular access, so that's another important thing to have in this patient. All right, Rabih, tell us more.
Okay, great. So after examining Sammy, you want to intubate the patient. So a code C is called when anesthesia comes, intubates the patient. Meanwhile, patient maintains good perfusion, hasn't lost pulse. So no code blue is called. The blood glucose is great. Many times it can be forgotten when there's a maelstrom of things going on. So checking the blood glucose 160, Narcan was not necessary. No history, as Rabih mentioned, the respiratory rate was too good. It would be suppressed, and that's another another scenario for a rapid response. And again, GAG was negative, so that prompts securing the airway. And during this time, you start to get a bit more history. You have a 34-year-old male, has a past medical history for end-stage renal disease, on hemodialysis, HIV, mood disorder, hypertension, and has a history of neurosyphilis, which was treated about a year ago successfully. And the patient came in the night before, was weak, confused, and had an episode of vomiting at home. He had come home after his hemodialysis session at around 2 o'clock in the afternoon and ended up in the emergency room about 5 to 6 p.m. In the ER, a stroke was suspected. He did get a CT, which didn't show any acute hemorrhage. CT angio was done, which did not show occlusions. So he was admitted to the floor, had also an LP, which did not show any abnormalities with white cells, protein. It was pretty much normal, you could say. And his altered mental status workup was ongoing with involvement of neurology. In the morning, he was kind of coming to when he was given some medications for his blood pressure, and the blood pressures remained up in the 160 and at the time of the rapid 190. So he got at 5 a.m. some medications that were crushed in applesauce, and then he proceeded to vomit right after that, and then everything went downhill. He was hypoxic with pulse ox into the 80s, and a non-rebreather was put on the patient, and a rapid response was then called. And I'll stop there as you mull over this new data.
Wow. Okay. So that's very helpful that we have now some past medical history. So he has end-stage renal disease on hemodialysis, HIV, syphilis. He has hypertension. Yeah, and CT and CTA was performed, and as we learned from the last RLR episode, that's what came for me to mind, is that maybe we did an LP, and all of these results were normal without any findings. So is there maybe something developing that we just didn't get early enough, and maybe like repeating some of those tests would be helpful? That I don't know, and I would just something to think about. Otherwise, that his hypertension remained refractory. I don't know. Was this the main finding, that his hypertension remained refractory to treatment, Rabih?
Yeah, actually got worse. He was getting intravenous medications. He got some medications in the morning, and he vomited them up, and the blood pressure shot up to near 200 systolic.
Okay. Yeah, I don't know what to make of that. So did he get IV and antihypertensives, or did he vomit up the oral antihypertensive?
So he got a mixture of IV and the oral he vomited up.
Okay. Yeah. So I don't know if we should start thinking about causes for secondary hypertension, or like intracranial process that's now like getting worse, and that's the reason why he has to increase his systemic hypertension to guarantee cerebral perfusion. Otherwise, I don't know if we could go down the sympathetic toxicity train, think about like endogenic sympathomimetics, or like exogenic. Did he take something? Is he having like withdrawal syndrome, or is he having like an endocrinopathy that's now manifesting? I would also repeat his blood sugar. Otherwise, I don't know. I can't make too much process right now, to be honest. Rabih, can you help me out?
Yeah, honestly, my friend, now you can kind of slow down, because you ask yourself, what could happen now that could be worse? You have his airway secured, his cardiovascular system is too strong, and his brain now to focus on. So I think in these situations, you're like, okay, now I can sit and breathe. And I think the connections you can start to ask yourself is, what is the overlap between AMS and hypertension as one thread to explore? And the other thread to explore is, how can patients with end-stage renal disease get altered mental status? And this is a good space to practice your reflex into these categories and expose the things you know less well. So for each of these questions, like take 10 or 15 seconds just to make your quick list. And then later ask yourself, what did I miss at my quick list, and what deserves to be in my quick list? So why don't you go for it for each one? Hypertension plus AMS, and then end-stage renal disease plus AMS. What do you think?
Okay, so hypertension and AMS. So yeah, first we would think about some intracerebral catastrophe that causes like AMS and secondary hypertension. Then I would think about sympathetic toxicity, thyrotoxicosis, drug or medication withdrawal syndrome, stuff like that, other endocrinopathies, meningitis, encephalitis manifesting AMS and hypertension, this would be my reflex thought in this direction. When I think about end-stage renal disease and AMS, you can get acid-base disturbances, you can get hyponatremia, you can get hyperphosphatemia, although I don't know if that manifests with AMS. Otherwise, you get medication and toxicity in end-stage renal disease patients, and always have to caution their use and their dosages.
Excellent.
Yeah.
Excellent. I'll tell you that that's superb. My list for hypertension plus AMS is prioritized by anything that can cause ICP elevation. So be it a focal lesion or diffuse cerebral edema. So elevated ICP. The other is that recognition that hypertension alone can cause an encephalopathy called hypertensive encephalopathy. So high ICP, the answer is in the blood pressure, or then finally, PRES, posterior reversible encephalopathy syndrome. What's my list for end-stage renal disease plus altered mental status? Infection, toxin, and missed dialysis. Toxin, missed dialysis. And the third is PRES. So what's on both lists? PRES. What would be CT negative and CTA negative would be PRES. Now, PRES is a rare diagnosis, but it tells you that I think the next step in this patient is a thorough medication review, and then also considering if feasible an MRI to look for occult diseases that don't show up on a CT like PRES. Questions about that, Sammy?
Nada.
Rabih, tell us more, please.
Okay, so now that the patient, wonderful discussion. Yeah, it's very difficult operating when you have so much limited data, and the cases and folders we usually discuss on CPS. But I think Sammy had hit the nail on the head to revisit imaging, and I'll bring up a snapshot of an unidentified image. I'll share it. Are you able to see that? So as you hand the patient off to the intensive care unit, he does go down to get a head CT, and you see then a remarkable intracranial bleed. So what's interesting is during the time he came in, he had the complete workup. He had the CT performed and the stroke workup by neurology, and it was all negative. But during this time, the patient's CT morphed into this. And also during his repeat exam, I forgot to mention, but he did have discordance with his pupils. So as he was examined by the ICU, his pupils had changed due to this development as well. So I'm not sure when this developed, but his neurological exam had also changed remarkably. So that pupillary discordance did indicate that there was something intracranial that was happening.
Wow.
Reflections?
Yeah, very humbling case. I don't know what to say. Medicine is just so hard. I mean, I wrote on my sheet CT is negative, but I thought about the recent RLR and that maybe we should repeat imaging in such a patient. And I love the thoughts from Rabih about the PRES and the overlaps from both of those. Yeah. Thank you so much, Rabih. I learned a lot.
Oh, thank you. You did remarkably well.
Your intern year starting in how many weeks?
2.
It should have started 2 years ago based on this discussion. That was absolutely superb. I mean, these cases really bring the heat, and I'm really glad that Rabih brought them to us. I think, Rabih, your point about that this is the clinical reasoning in 30 minutes is meant to be like fast clinical reasoning, and clinical reasoning in a rapid response is 30 seconds of reasoning. You know, that's all you get. And we gave Sammy 2 sets of 15 seconds to come up with this list. And I love the pearl that you're emphasizing is if the patient is getting worse, instead of moving on to the next step, you often have to say, well, how good are my initial tests and do I need to repeat them? And I think the most recent RLR case is a great example in the abdomen of that issue. And this is a great example of this in the chest. Rabih, what was it like for you to be part of this case or hear about this case? I'm not sure what your involvement was.
Oh gosh, I was sweating buckets because I had absolutely no idea about the patient, but just it's interesting when you're in real time moving through a case like this. You go through, I mean, the missed mnemonic is just a great useful tool to have. And you go through, like exactly what Sammy had mentioned, the glucose, see if there's any narcotics on board, check the airway as well, so get the patient's airway protected. And then you have some luxury of time then also sending for re-imaging, because hours had gone by and things can transition or new things could develop. And then the HIV I kept anchoring on, could this be, because it was a fever as well, but I think the fever was from the aspiration event that he had. So he did also develop a right-sided pneumonia from that, vomitus. But with HIV and thinking slow, could this be a manifestation, especially with that history of neurosyphilis, could this be a remanifestation of that? But then I had to sort of snap out of it and work on securing the patient and getting that CT urgently to see what was happening with the patient. And I'll just share, I think I have for a second, the hypertension and AMS, because this is something I've encountered before, and both of you hit on a bunch of these things here, but just with the hypertension, AMS, hypertensive emergency, encephalopathy, press and sympathetic stimulation, and you have to think about stroke with the compensatory hypertension, because that ischemic penumbra, if it's a hemorrhagic stroke, or the other thought that I had is, could he have had a ischemic stroke, which won't be picked up on a CT? It would be picked up in the initial 24 hours on a MRI. Could it morphed into a hemorrhagic stroke? So with a stroke like that, you do have compensatory hypertension to protect the ischemic penumbra.
Just so much learning, Rabih. So much. Thank you. Sammy, maybe to model and reflect our teaching points from today, instead of anybody else recapping them, what would you say is your summary of the teaching in this case?
Yeah, just the overlap of AMS and hypertension. I didn't think of it for a long time, and I was expecting more of a sepsis or like a hypotension like case. But yeah, very important to also think about hypertensive encephalopathy, but I think it's more like a diagnosis of exclusion. And it was very necessary to get this repeat imaging, and just to not forget that once a test is negative, that doesn't mean that it will stay negative, and just to get repeat testing if the suspicion is high. And yeah, that's basically the main teaching point for me. What about you, Rabih?
Oh, I think for me is what you said about the repeat testing, but I think principally it's a great exercise to recap how systematic you were when somebody is critically ill: A, B, C, D, E, airway, breathing, circulation, and keep going beyond that. I think that is absolutely key. Rabih, I'll hand the mic to you to tell us your major recap from this case, and we'll say goodbye to everybody.
Yeah, I would just finish it out with just saying, anytime you have somebody with altered mental status, I think the tool that you could use is the MIS mnemonic, and then implementing the emergency measures which Sammy and Rabih and Nessie laid out. I've been in many rapid response simulations where glucose is missed. Also check for any narcotics, and it doesn't really harm. It's pretty cheap to give some Narcan, and also do evaluate the airway, and then also do move down the different branch points once you've stabilized the patient, as Sammy had nicely outlined: airway, breathing, circulation, and so on. So I think that pretty much sums up the learning from today's case, and I hope everybody learned something and can actually use this in real life and help somebody who's in distress.
Amazing, Rabih. We forgot to ask you what ended up happening to the patient, if you know.
It didn't work out. It was just such a massive bleed. It was just very difficult to help save the patient, but everybody tried. It was very interesting, the sequence of events that we were able to find out. If he had presented initially with it, maybe chances were better, but maybe due to the number of hours that it wasn't worked up.
Yeah, no, I mean, I think intracranial bleed is devastating mortality, let alone one that is that big. Alrighty, well, thanks everyone. This was amazing, Rabih. I hope Rabih has inspired all of you to think about bringing your acute cases. It goes to show you just how powerful all aspects of clinical reasoning are. So thank you, Sammy, for diving in the deep end today, and thank you, Rabih, for an amazing case. All right, y'all. Bye.
Bye.